If men experienced painful sex, bleeding, and a complete loss of function during midlife, would we have fixed menopause already?
Yeah, your average gynecologist, which I put myself in that group until I learned about this on my own, are not taught anything about this. Isn't that amazing? In medical school and even in an OB-GYN residency, we got zero, like not even any training about how to manage menopause. So that when I went through menopause, I didn't even know what was happening to me. Thing that we were told all these years and still frequently are told, yeah, you just sort of put up with it. It's a normal part of life. Just buckle up and carry on. And there's not a chance that that would have been the way it would have been looked at if it happened to men.
Well, welcome back to my channel. I'm your host, Life Coach Meg Ellis. I am here with one of my favorite, one people ever, but one of my favorite guests who's been on the show. You have seen her many times before. Dr. Susan is how you know her. Dr. Susan Hardwick-Smith, who is a board-certified gynecologist and menopause practitioner. And she's also the founder of Complete Midlife Wellness Center and this facilitator of this most amazing retreat that I get to be a part of. We'll talk about that later. Dr. Susan, thank you for coming back on my show.
Well, I'm so glad to be back. And that was a whole mouthful of stuff you just got out there. Really good job.
Well, thank you for coming back, because today we are talking about this hot topic. And it's actually a topic that I have been hit up with on my social media platforms from women everywhere who feel clueless about the perfect topic for you, because you are literally the expert in it. Perimenopause and menopause. We don't know anything. Help.
Yeah, we really don't. And we, meaning including doctors, it's really amazing. Your average gynecologist, which I put myself in that group until I learned about this on my own, are not taught anything about this. Isn't that amazing? In medical school and even in an OB-GYN residency. So I went through 4 years of med school, 4 years of specialty training in women's health. We got zero, like not even any training about how to manage menopause. So that when I went through menopause, I didn't even know what was happening to me. So the fact that your listeners don't know about it isn't really surprising, because even doctors don't, but it's getting better. So there is that. There is a specialty now in menopause, and I'm part of that, trying to help spread the word. So here we go. We'll try to spread the word.
And we are so thankful for you. I always call you a trailblazer, and I truly believe that. You are one of the trailblazers spearheading this, the stigma, this taboo around menopause. Nobody knows anything. And people, it's just this taboo topic, and people don't even know what questions to ask. And I will share this. I know a little bit more than the average person, just because you're one of my good friends and we talk about this stuff, and I attend a lot of your events. But it wasn't until a couple years ago, even, I remember I was sitting around with some friends and I was like, oh yeah, menopause. Yeah, no, I don't have to go through that because I'm not having kids.
Makes sense. Not really, but hey, makes no sense with anything when you don't have any information, right?
I had no information. Who had to tell me that who burst my bubble was a gay man, one of my friends, bursted my bubble and said, I don't know, Meg, I don't think that's how it works. So this is where we're starting at. We're starting at zero here. And I had a bunch of people on my social media following write in with questions for you. So we're going to hit all these topics. Perimenopause. What is it? Menopause. All the things that your body goes through, weight gain, libido changes, hormone replacement therapy. We have tons of questions, and we are going to try our best to get through this. And I have a feeling we're going to have a part 2 of this.
We might. This is a 4-year degree in less than an hour. So let's go.
Let's go. Here's the first question. If men experienced painful sex, bleeding, and a complete loss of function during midlife, would we have fixed menopause already?
Yeah. I mean, it's really this whole lack of education around menopause really highlights that we still have a massive inequality in research dollars, in education when it comes to men and women. Absolutely. I mean, it's sort of amazing that we were told all these years and still frequently are told all of these symptoms we might experience, which we'll talk about later. Yeah, you just sort of put up with it. It's a normal part of life. Just buckle up and carry on. And there's not a chance that that would have been the way it would have been looked at if it happened to men. And we all know rectal dysfunction. That was one of the fastest drugs ever passed through the FDA to get Viagra approved. And we still can't get some very natural hormones approved for women. So, not to start a conspiracy theory, because it's just the truth. We're still fighting for women's health. So women, we got to fight for it so that we can become equal, because it's really amazing that this is still happening in this day and age, but it is getting better. So I want to leave it on a hopeful note. We are learning and we're doing stuff like this. So
yes. Yeah. And once again,
crazy.
To people like you. So I guess the first question, we'll start off kind of basic here, is what is perimenopause? What is menopause? Break down the two. I don't even know the real difference between the two.
Yeah, well, I'm going to even back up a little bit and go back to the beginning. So just super elementary level, because a lot of us didn't even learn this in middle school, right? We go through puberty, right? Let's just say as women, we're an average age of 12. And then we start producing hormones from our ovaries. We start releasing eggs every month. Some women don't even know this. If you're not on birth control, we release an egg approximately once a month. We don't get pregnant. The lining sloughs, that's your menstrual cycle. And then it starts over again. So the three primary hormones that we make starting at age 12, estrogen, especially one called estradiol, because there's more than one, progesterone, and
I didn't know that.
Testosterone. Yeah. So three big hormones. And I'm going to just, say testosterone. Fun fact, we make more testosterone than estradiol as women. That's a fun fact. Throughout our lives, we make a lot of it. No, 10 times less than men. But up and down, we're making these hormones from around age 12. Now, there's different changes, of course, if we go on birth control, or changes when we're pregnant. But let's just pretend we're having once a month cycles. Maybe yours are not perfect, but you get the idea. Now, when we go through menopause, average age of 50 to 51, that completely stops. We're no longer producing any of those hormones from our ovaries. So we're not having periods. If we drew your blood, your estrogen level would be 0 or very close to it. So would your progesterone. Testosterone would be close to 0 too, or very, very low. So we've got lots of hormones, and then menopause, we've got none. So in between, there's a period of time that we call perimenopause, when it's not perfect. We're not fertile necessarily anymore. We're not ovulating every month anymore. The hormones are starting to be produced in a really wild and wacky manner, not predictable. And up and down, very, very zigzaggy. We call it kind of wild and crazy, commonly roller coastery. And then eventually it stops. So perimenopause is just that middle part. So it hasn't stopped yet, but it's not functioning normally. It can last for 10 years. Or it can last.
Wow.
Yeah, it can. So an average of 5 to 7 years of just very wacky hormone changes. Now, some women are lucky and they don't experience the problems that we're going to discuss, but many or most women do. And we've been told all these years, she's just hormonal, because women's health problems are usually just racked up to she's just emotional. It's all just psychological. She's just hormonal. She's just having a bad day. She's on her period. That kind of dismissive language we use around that.
Yeah.
Actually, she can be feeling anxious, depressed, even suicidal, like miserable, losing her memory, losing her sex drive, gaining weight, literally symptoms head to toe. And we're just told to go off in the corner and don't complain. Typically starts late 30s, early 40s, lots of range. I mean, it's a massive range. So it's just unpredictable. That would be the word. You can't say it's going to start when you're 40 and then when you're 50. That's average, but average is just average, right? So
right.
That's the short version of the big, long story.
Yes. And I'm going to refrain from saying, wow, I didn't know that, because, that would be half the podcast, because, I really don't. Right. And I got some really great questions in from just people on social media. And one of them was about that, thinking that they're going through perimenopause, but having these symptoms of depression where their doctor was just saying, oh no, you're just depressed. Just get on antidepressants.
Yeah, so common, like super common. Because if you go to a doctor, remember I told you we're not trained. So you're going to see someone who knows nothing about this, and you're saying, oh, doctor, okay, I've lost my sex drive. I don't have any interest in social activities. I'm not sleeping very well. I cry a lot. I feel sad. They're just thinking, oh, ding, 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 depression. Let me write you an antidepressant prescription because I know about that. I remember that from med school. And also that'll get you the heck out of my office because I don't really want to talk about this. You remember, doctors are human. If they're faced with a complex problem, and this is probably the epitome of the complex problem, right? There's no, okay, write a prescription and off you go and you're better. It takes a lot more than that. We want you to go away. Let's be honest. We're like, I don't know what's wrong with you, so please get out of my office. So write a prescription, off you go. So dismissive. And then now you're on an antidepressant that you don't really need because you don't have a dysfunction in your neurotransmitters. So it's not going to help, number one. And now you're going to become dependent on a drug that's really hard to get off. And you won't feel better because it's not treating the root cause, which is hormone imbalance. So, not to blame those who are not educated, because I was in that group. I used to do that when I was a younger doctor. That's exactly what I would have done. And I'm so sorry, all the people that I did that to, because I didn't want to.
Yeah, well, now you do. And that's the point that's what evolution is, right? We didn't know better and now we do. So let's do something about it and let's continue that knowledge. So that's going to segue right into, I got a ton of questions about hormone replacement therapy because there's so much stuff all over the internet. As you know, if you want an answer on the internet, you can find it. So let's talk about what HRT or hormone replacement therapy is, where it started, what it can do. I'm going to just let you take the reins here because you are the expert.
Well, I'm going to just really make this short if possible, because that subject has been the topic of very long books and very long courses that could take months. So the PC term now for what we used to call hormone replacement therapy is menopausal hormone therapy, just to say, if you want to be fancy, we call it MHT now, just because we always like new words for stuff. So I'm going to just jump to the easy part, right? Let's just imagine your perimenopause is very tricky. So we'll deal with that a little bit later. We will deal with it. But menopause, so now we're in a state, you come in my office, you've stopped having periods. Now, the textbook says you haven't had a period for a year, but you don't have to wait a year. What happens is, at any point, if your ovaries have stopped producing estrogen, progesterone, testosterone, and you're feeling all kinds of symptoms, we can name some of the common ones. Women have hot flashes, night sweats, memory loss, mood swings, anxiety, depression, loss of sex drive, muscular pain, literally head to toe. You can have hair loss and plantar fasciitis, every single thing in between. I've never heard anyone describe it as pleasant. Let's just say that. So the number of symptoms are more than 50. So you're coming in with these symptoms, and we can replace those hormones that you've made all your life, estradiol, progesterone, and I'm going to say testosterone because that's also important, and all those symptoms go away. Well, that sounds great, doesn't it? Super simple. And it actually is super simple, but the whole thing got really fuzzy. In 2002, there was a very big study that was published that suggested that hormone replacement therapy was dangerous. It was a long time ago, but it takes a long time to get misinformation out of your brain once it's been put in it, right? I mean, people used to think that tanning beds were safe. People used to think the world was flat. It took a long time, I bet, before they believed it was round. I mean, so here we are. It just isn't true. So more than I can tell you in this podcast, but long story short is that study was reported incorrectly. In fact, there was not any increased risk in breast cancer, heart disease, or stroke that was of any significance. We know now that using the hormones that we have available now, which are different than the ones they had back then, not only is safe, but it's beneficial for almost every woman. I would almost just say every woman, just with a couple of exceptions. Prevents death from heart disease, osteoporosis, Alzheimer's, colon cancer, helps with sexual function, mood, sleep, weight management, every single thing that I just mentioned. So
who doesn't want that? That sounds amazing, especially if you're going through all those symptoms.
It makes the symptoms go away. Now, I'll just say, when I was having those symptoms, if you had told me, I'll give you this hormone and your symptoms will go away, but you have a 10% chance of dying from cancer, I would have still said, great, give it to me, because I felt so terrible that I would have taken that deal. But actually, we don't even need to make that deal anymore. You can take it and feel better and improve your risk of getting all those chronic diseases. So you actually live longer in a healthier state and feel good. But the problem is we've got all this misinformation that was fed to people through the media. This is one of the best examples of how the media can misinform the population with something that this was so serious. I mean, tens of thousands of people died and are still dying as a result of that misinformation. So it's just really no joke how bad that was.
Yeah.
But now that we're coming out of that and understanding, this is not just my opinion. I mean, this is science supports that we need to replace those hormones when they disappear. Even if you were that 1 in 1,000 women who just said, oh, I feel fine, I don't have any symptoms. Osteoporosis, heart disease, Alzheimer's, all of those things are going on in the background, even if you feel fine. I mean, you probably won't feel fine, but it doesn't just treat feeling better. It treats your longevity and your health. So yeah, we need to spread the word about that. And the sooner you start on it, the better. Because as you imagine, if you've had years without it, just say you had 10 years and didn't take hormone replacement or menopausal hormone therapy, some damage has already been done. So what we want to teach women in your age group is as soon as you go through menopause, you want to start on it so that there's no break. And then you don't have the damage. So it's actually preventative.
That sounds good. Sign me up for that,
Right. Easy, right? So it's simple, but not easy because we're trying to undo this vast amount of misinformation that was fed to humans, including doctors. So there was still many, many doctors that tell patients that menopausal hormone therapy is not safe, which is crazy because it's just wrong. I mean, it's not even my opinion. It's just flat out wrong. But, we're human beings. Doctors don't always get much education after they graduate from school, and they're still talking about the same stuff they learned 25 years ago. So
I know. Yeah. That's the thing. It's just, again, evolving and getting that new information. It's like, why would you not want to evolve and use the latest information? That just makes, it just makes sense to me. So,
and then you think about though, you go to the doctor, right? And they make you wait a couple hours and then they see you for 15 minutes. These people are busy. They go home and they take care of their kids and eat dinner and fall asleep. They don't have time to be reading journals and keeping up with stuff because the whole medical system's so effed up. So a small group of doctors who are able to spend more time, I retired from that in 2020. I was just burned out, honestly, with practicing that way because I couldn't help my patients and I felt terrible myself. So, finding someone who's really specialized in menopause is really important because they have taken the time to learn. And not everybody has. I mean, not their fault. They just don't have time.
Yeah. So find a specialist is what I'm hearing. And I love coming into your office. It's beautiful. It's pink. It's gold. Everyone's so nice. And it's just so feminine. And you have longer appointments where you don't just feel like you're pushed in and pushed out, and you just opened your location, which is amazing.
That's right. Yeah. There's a lot of need for it. So we're excited to be able to serve more people because there's so many people. Only 5% of women who should be on menopausal hormone therapy in the United States are. Only 5%. Wow. The other 95% it has not been made available to them primarily because their doctor hasn't gotten this information. So, or the patient herself is still full of fear because of something she heard from years ago, right? Just fear and misinformation.
Yeah, right. It's not like we're still, smoking cigarettes and hitting up tanning beds. It's like you gotta get with the new information. And that's why I wanted to have you on this show because so many people are asking and it was just so clear, just even in my daily conversations, let alone the online conversations and, my own narrative of, I don't know much.
So I'll just tell you
how much we don't know.
Oh, totally. And for someone, and every woman, every person should know this information about what happened with that study. I mean, that's a piece of information that everybody in the world should know. And it's a lot to know. There's a fantastic book called Estrogen Matters, written by Avram Blooming. He's an oncologist. He's a real life doctor, and he really digs into exactly what happened. So if you're curious about how the heck did that happen, he just lays it all out. And it's a really great book. So women everybody is going to go through menopause. Nobody gets to get out of it. As you're starting to think about it, maybe you're in your late 30s or 40, read it just so you're like, hey, this is what happened. I understand that thing that happened in 2002. And so I can teach my friends, I can understand the questions to ask. I think that's just a key piece of information that we all need to know.
Yes, yes. And I will be tagging any resource that you mention and obviously your channel, because you have, well, one, you have beautiful offices, all over Houston. Two, you have your social, even your free social media platform is just so educational, and you just talk about so many topics. So, YouTube, even Instagram, all that stuff. I'll be tagging all of that because yes, this is going to be a little teaser episode, but you produce this content every single week. So if somebody wants more, they can always, come find you on your channels too.
Or just giving you some, trying to get you excited so that you'll go learn more, because this is something every woman needs to know about our bodies, right? Like the fact that we were not taught about how our own bodies work, it's kind of amazing.
I know.
Shocking, horrible, amazing, right? So now it's up to us.
Are they teaching about it now?
Not really. I mean, a little bit more, but not much. And there is this specialty, and it's not even a really recognized specialty of menopause, but we have our menopause society. You can become a member of it and learn. So there's more education out there, but the average OB-GYN, no, we're taught to deliver babies, do hysterectomies, put people on birth control, all really important stuff, but just really still no particular focus on menopause.
Yeah.
Still ongoing.
So going back to the MHT, menopausal hormone therapy.
Got it.
It's beneficial to take when you begin menopause, and then even afterwards, even if you're not experiencing any symptoms, or you don't think that you need anything, quote unquote. But how soon? What about before? So let's dive into that perimenopause.
Yes.
Gray area.
We started with the easy stuff. When your hormones are zero, and we're going to talk about drawing your blood, which I think personally is really a great tool. But let's just say we drew your blood and you're 50 and all three of those hormones are zero. Okay, that's pretty straightforward. We can replace it. And there are various ways to do that. Maybe too much to talk about today. The current thought is that you want to take that forever, because when you stop it, those problems will come back. Your risk of those diseases will come back. So you don't want to stop it when you're 70 or 80 or any age. Take it forever is the current thought. Okay, so that's easy. Now, what if you're in that bucket in between, right? That's more tricky because you're still making those hormones. They're just in a very zigzaggy, crazy manner. So there are definitely things that we can do to help women in that case. Now, for example, if you're making lots of estrogen, but it's like super high one day and super low the next, I don't want to give you estrogen every day because then it's going to be too high on some days. So we want to really look at those. Each patient's an individual. And so I firmly believe, and I know some of my colleagues disagree, but we want to check some blood work and see where you are and then make an educated decision about exactly what you need. So typically in perimenopause, the two hormones that are low. So we were taught, we weren't taught anything, but we were led to believe as doctors that you have periods and then they just stop, right? So you got hormones and then they just stop. Right, that's what I thought. And there wasn't really anything in between. Like everything's fine and then it just goes away.
Yes, that's what I know. I feel good. I know something.
And even more than that, all three of them all go away on the same day, right? No, that is not at all what happens. Actually, they go away at different times. So one of the first things that happens is we make less progesterone. So we make progesterone after we release an egg. It's called progesterone because it's progestational. It's made to help keep the little embryo alive if you get pregnant, right? So you make a bunch of progesterone after you ovulate, waiting to see if you're pregnant. And then if you're not, you have a period. Well, as we get older, we make a lot less progesterone. That's one of the reasons why we miscarry more when we're in our 40s. It's harder to maintain pregnancy because the egg's kind of getting old and it's not making as much progesterone. So we can suffer from low progesterone even when we're still having periods. And we're like, what the heck? I feel all these symptoms, but I'm still having a period every month. Absolutely, that can happen. When your progesterone's low, you feel like you have PMS all the time. That's how I describe it to my patients. Mood swings, sleep changes, memory changes, grumpiness, sugar cravings, all kinds of things happen. And if you go see your doctor and you're like, I'm still having a period every month and I'm 40, they're like, you're fine. All of the things you just said must be depression, just like you said. So here's
take the antidepressants. Yeah.
But actually your progesterone's really low. So that patient might do really well taking progesterone only for example, because maybe that's the only thing she has that's low at that time. Another hormone that can drop before menopause is testosterone. When I was 45, my sex drive went away. I was losing muscle. I'm an athlete. I wasn't as strong. I'm like, what the heck is happening? My testosterone was zero. It was unmeasurable. I was still making estrogen. So just to say, I replaced that and all of those symptoms got better. So in perimenopause, we don't necessarily need estrogen, but typically progesterone, maybe even testosterone might be low. And how would we know that? We'd have to check because everybody's different. It's not like here's your prescription, off you go.
Right.
You've got to look at you, individual person, your lifestyle, what's going on, measure your hormones on the right day. That's also key. Because of course,
how do you know? How do you know what the right day is, especially if it's up and down, up and down?
Right. Well, so if your doctor just checks it on some random day, they might be getting it on a really high day or a really low day. So the standard is to check when you're on your period, because that's when your hormones that's when your estrogen is the lowest. So if you're perimenopausal, so you're still having periods and you get your hormones checked, there's actually 2 times of the month that are ideal, but not just some random day, because who knows what that means. When you're on your period, so typically we say on day 1 to 3 or so of your cycle, because that's when your estrogen is really low. So we want to find it at the worst time. Mm-hmm. If you're complaining, like maybe some patients say, I'm having hot flashes and night sweats during my period, and then they go away. Well, of course they do, because your estrogen goes back up again. So we want to find it when it's going to show the symptoms that you're talking about, so we don't accidentally tell the patient, oh, your labs are fine. It must all be in your head, right? Because that happens.
What if you have an IUD and you don't get a period?
Right. Well, so there's a whole class of patients who don't have periods for whatever reason. Maybe they have an IUD, maybe they've had an ablation or even a hysterectomy, and they still have ovaries. I was one of those patients.
So you still go through menopause even if you've had a hysterectomy or your ovaries removed?
Not quite. So menopause.
I'm asking too many questions at once. I'll let you.
No, this is a really good question. So if a patient has had some reason why she's not having periods, but she still has her ovaries, like an IUD, an ablation, or just had your uterus removed. So I had an ablation, which is a procedure that makes your periods stop. My ovaries was still there. So the hormones was still doing their thing, but I wasn't having a period that would tell me when to check anything, right?
Yes. Yeah.
So in that patient, we have to just use a lot of detective work. We check at a random time, and then we try to make sense of it. And then we have to check again at a different time. And you can see it can get really complicated. It's not a 5-minute visit. It takes sometimes several visits for that patient to find the problem. We've really got to go in believing that the patient is telling the truth. And I'll tell you what, like, that sounds so obvious, but there's such a stigma about women's health where there's often, not all the time, I don't want to be judgy about all my colleagues, but patient comes in and she's got a bunch of vague symptoms, and there's just this sort of voice in the back of the doctor's head that she's just crazy. Like she's not telling the truth. And then, or she's just depressed or whatever. There's sort of this underlying current of idea that this isn't really a real problem. Mm-hmm. It's like, rah, 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 she's just complaining. She's just hormonal. And you can sort of feel it. It's so prevalent in society.
Oh, yes. I've been dismissed by my previous OBGYN.
Totally. And so if that doctor checks the patient's labs and the hormones happen to look fine, because we just happen to check them on one of the few good days of the month, they're like, oh, see, she was just nuts. Should just send her off to the crazy clinic. So we got to have someone, first of all, that believes the patient. So if you come in with a list of symptoms and the labs don't show what I thought, the labs are wrong, not the patient. Like, we've got to believe the patient. We were just checking it at the wrong time or something. We go back in and keep digging. So that's one of the core things I think that we have to believe, that this is happening because it's real. If you're 40 and you're listing 500 perimenopause symptoms, guess what? You're in perimenopause. You don't even really need labs to show it, but they can be really helpful for the reasons that I mentioned, because people can be lacking one or two. I mean, not everyone's the same. Some people, their testosterone doesn't drop. Mine did. That patient wouldn't benefit from testosterone. So I don't think it's right just to prescribe without really doing that detective work.
Yes. So I'm also, and we'll wrap this up at the end with just little things that people should be listening to. Like, clearly, I think everyone should come see you because you changed so many people's lives. I have my friends' lives, people in the retreats, just magical. But a lot of people don't have access to Houston or whatever. So I would like to wrap up the episode at the end talking about like things to look for in a practitioner. So as we continue throughout the episode, just keep listening for those kind of things if you're listening. Because, you know,
and you can tell too, like, I just wanted to interrupt you, but like, don't be afraid to, tune into your gut. If you're talking to a doctor and you feel dismissed, or they're not listening to you, or they're giving you an air that they think your symptoms are BS or made up, or that you're nuts, I would just say thank you and walk away and find somebody else. Like doctors are just people. You have the right to not connect with one and find a better one. I think I sort of grew up thinking your priest or the attorney or the doctor was always right, and you just believe what they said. No, that's
just humans.
Right, exactly. Yeah. So got to find one that you connect with, and there's lots
who is testing you. You know, my old OBGYN, I had gone in with a couple of symptoms, and I was thinking, like, this is off. This is a change in the last year. I'm approaching a certain age. And he didn't even test me for anything. He didn't even offer any labs. He was like, you're too young.
Yeah, right.
And I was like, but you don't know anything about me, you know?
That's an interesting comment, because women can go through menopause in their 20s. Now, granted, that's very rare. But, if anyone says you're too young, that's red flag number one. You're not too young. Certainly the common age to experience these symptoms might be in our 40s, but many women are in their 30s and sometimes even earlier. So yes, you're not too young.
Yeah, know your body, tune into your body, get a trusted practitioner who is educated and willing to test you and spend the time and really, like you said, do the detective work.
That's right.
So into the perimenopause gray area here, you're getting a period still. It might be starting to become irregular. Mm-hmm. When is there like a good time to get on the menopausal hormone therapy before you go through menopause, or what's the buzz on that?
Yeah. So, because it's so variable, the nature of perimenopause, this part in the middle, when it's done, it's easy, right? Menopause is easy. Your hormones are zero. That's pretty straightforward. Perimenopause is much more complex, and there's so much variation, that there isn't one single right answer. Sometimes hormones are so wacky and up and down that a really good approach for an individual woman might be just to go back on birth control pills. And I know that sounds strange, because maybe you don't even need birth control, but it makes your hormones the same every day, because it basically puts your ovaries to sleep. So birth control pills work by shutting down ovulation. Essentially, your ovaries are in hibernation when you're on a birth control pill. And if they're doing all kinds of wacky stuff that's making you feel terrible, that's not a bad idea. So, that could be an approach for some women. Other women might just take progesterone. Other women might just need testosterone if their primary complaint is lack of sex drive, for example. So there's just so much variation. So I would suggest that when you should start looking for an answer is whenever you start noticing anything's different. And so I was taught, again, I told you a lot of times we were taught not correctly, that your period's always going to start becoming irregular. And then if it's regular, then you're fine. Well, that's not true for the reasons that I mentioned. You can have regular periods and still be perimenopausal. Now, you might notice mood swings getting worse, or some of the other symptoms that I mentioned, or you might skip a period, or they might get closer together. Sometimes they're every 21 days instead of every 28, or sometimes they get really heavy because with less progesterone, you make more lining. So all these kind of things can happen. But if you can tune into your body and believe yourself, like trust yourself, if you know something's not right, don't let someone tell you you're fine. Yeah. I can't even tell you how many times I've had a patient come and tell me, and I promise I said it too before I knew any better. You're fine. It must just be in your head. Trust yourself if it feels different. Now, if you do really feel fine, if I ran the world, every woman around 40, we would get a baseline set of hormones on her menstrual cycle just to see where she's starting from. And maybe we don't do anything at that point, but then we know where you're starting from. Because we know what's going to happen, right? No one's going to get out of this without menopause. So it's happening. So if we got a baseline set of labs when you were around 40, And then we could just tuck that away for later. So now you come back 3 years later and you're like, oh, I'm starting to feel different. We can compare, like, okay, has it changed?
Yeah.
Has this changed since before? Like, that's super useful if we can get that information early. Normally, we don't have the option to do that because people don't typically come into the doctor when they feel well, right? We're taught to don't go to the doctor unless you're sick. I want patients to come in when they're well so that you don't get sick. It's a different approach.
Much better.
Wellness medicine is just a different angle. It's like, don't wait to get sick. Let's check you when you're well, because we know it's going to happen, right? We can 100% tell you're going to go through menopause.
Mm-hmm.
So why not have a baseline to see where you're starting? I mean, it just makes perfect sense. Mm-hmm. But wellness medicine isn't the Western way. We just say, come back when you're sick. And then we'll try to
let's treat it versus let's prevent it. And that's bringing me back to my dental hygiene days, where you take x-rays every 6 months or a year, even if nothing hurts. But the tagline for dentists is don't wait until it hurts. It's the same thing where it's like, why don't you test yourself when you're well, so you know what that actually physically looks like in numbers?
You put oil in your car. You don't wait for it to break down on the freeway, right? You do it ahead of time. Right?
Yes, before. Right. Okay, so you're telling me I can wait till I go through menopause, experience it, and then mitigate it.
Try to fix it.
I can test myself now and prevent it.
Yeah.
Not prevent the symptoms, not the actual menopause.
Yeah, it's happening, right? But we can intervene early if we know, like if you know something's going to happen. Like if you see two cars, you're watching a video and there's two cars and they're heading for each other and they're about to crash, you could just wait for them to crash and then employ a bunch of really expensive ambulances to pick up the pieces and fix the broken bones. Or you could tell them to turn around. Right. Like, that's how I think of wellness medicine. We're just intervening before the crash, because it's coming. No one's going to get out of it without menopause. Like, so we makes sense to me anyway.
Yeah, that it does make sense. And when you break it down like this, it just makes sense. So
you will hear if you go to your traditional doctor and you're like, oh, I heard on this podcast that I should check my hormones during my cycle when I'm 40, just as a baseline. A very typical answer is going to be, oh, you don't need to do that. It's too expensive and insurance won't cover it. And you don't need it because you're fine. And just a massive amount of pushback, because that's what we were taught. Mm-hmm. We don't want to see normal labs. We don't know what to do with that. And doctors are taught how to take care of problems. So at least traditional medicine. And I was one, no judgment, but it's just so eye-opening once you're have to advocate for yourself and say, and you can go to places like Any Lab Now, or just, there's ways to get labs done, even if your doctor is telling you not to.
Yes.
So sad that you have to do that. But you will be turned away, probably.
Yeah. Yes. And that's why, again, listen to your body,
right?
And get a practitioner who is going to invest that time in you, right? Yeah. There is one squirrel that I wanted to go back and collect that we talked about before with the hysterectomy, or maybe having an ovary removed. Because I did have one person write in about that, how they had not a full hysterectomy, but one ovary removed. How does that affect perimenopause, menopause? So if somebody has gone through that, either just ovaries or full hysterectomy, how does that affect peri or full menopause? And do they have to do anything different, or what should they do?
Yeah, so it does add an element of trickiness and diagnosis that we already alluded to. If you're not having periods, but you still have one or two ovaries, so you're still making hormones. If you have one ovary removed, the other one picks up the pace for both. Just like if you have one kidney removed, you can live with one. So one ovary, typically you're going to produce hormones just like if you had two. So if you have an ovary, even part of one, typically your hormones are going to be still produced. But if you've had a procedure so that you're not having a period, the thing that mostly affects is more difficulty in diagnosis. So I was that one of those patients. Like I said, I was 45, had all these symptoms. I didn't think it was menopause probably for about a year. And I was a gynecologist who was treating patients for menopause because I thought it was too early. It just makes no sense. So you just went right over my head. So yes, if you're that patient, it adds an extra level of complexity. But if you have one ovary or two, you're going to go through the same process. You just won't have the period to be able to tip the doctor off or, that something's going on. Now, if you've had both ovaries removed, that's menopause. So if you have both your ovaries removed when you're 35, you went through menopause at 35 because you've got no ovarian hormones. So
that would be early menopause would be, and is a hysterectomy, is that ovaries and uterus?
The language that we use as physicians, hysterectomy is just the uterus.
Just the uterus. Okay.
However, in the community, some people think it means everything. So we have to really dig into what do you mean by that? Like when you say, if a patient says, oh, I had a hysterectomy, we're like, what did they take your ovaries out? Or, so the language is so confusing, but in medical terminology, hysterectomy is just the uterus only, not the ovaries.
See, I'm going to say it because it's been at least 30 minutes since I said it. I didn't know that.
And most of your doctors don't know that either. So, but we call it surgical menopause. So you can go through menopause naturally just because the ovaries stop producing hormones on their own, or you can go through surgical menopause because you go in and they take your ovaries out for some reason. But then the next day you've got no hormones. So that's the definition of a BREP.
Okay.
That patient needs to be on hormone therapy before she wakes up from the anesthetic. So what we do these days, that's exactly what we would do. We would put an estrogen patch on that patient while she's still practically asleep because the symptoms of that are so horrible.
So going into that, what are the options for hormone replacement? The patch, like you mentioned, there's creams, there's pellets.
Yeah, there
different
are
options for different people.
Right. So lots of options and mostly depending on your lifestyle. So just going back to the assumption that we are all in agreement that it's safe with the very few exceptions. Let's just imagine you're not in one of those very small groups. When you're menopausal, and I'll just go with the easy diagnosis, you got no hormones. That one's easy. Estrogen should not be taken in pill form. Long story short, it's not good for the liver. It can cause a couple of minor issues. So we give it across the skin. So a patch is FDA approved. It's a little sticker that you put on. Cream, a gel goes through your skin. You can get a little pellet that goes under the skin. Now, pellets are not FDA approved, not because they're bad. It's just because there's a long process to get FDA approval. It's the same exact stuff. It's questions, do you want to put it on top of the skin or under the skin? It's really personal choice. So estrogen is available in lots of different ways. Progesterone we typically take by mouth because it's not bad for the liver and it has this wonderful effect of making you sleepy. So we take it at night. Very commonly, women who are having hormone change have sleep issues. So we love it. I love my progesterone. Helps me sleep. It's great for hair, skin, nails, prevents uterine cancer. You have a uterus. So that one's a pill. And these are FDA approved. You can get them from any pharmacy, Walgreens, CVS. You don't have to go to a fancy compounding pharmacy. Only exception is a pellet because it has to be placed in the office by a physician. And then testosterone, again, we don't want to take it in pill form. We don't have it yet in an FDA approved form for women. We can get the male stuff and divide it by 10 because we get 1/10 the dose of men. It's really hard to do that. I'll just tell you, if you get a gel packet from the pharmacy and try to divide it in 10, it's imagine getting a ketchup packet and trying to accurately divide it. Quite tricky. So people, it's not my favorite. Or you can get it made by a compounding pharmacy. There's lots of really reputable ones. Again, that could be a cream or a gel you put on your skin, or again, a pellet under the skin. That's the same stuff. So a lot of people, some of my colleagues and different influencers get super excited about, this is great and this is terrible and pellets are bad or patches are great. It's the same stuff. Doesn't matter.
Okay. That's good to know because I think there's a lot of talk about that, just a little bit of confusion.
People love it. I have opinions about stuff. And the fact is, it's the same exact stuff. It's just, do you want to put it on top of your skin or under your skin? And I'm an athlete. I swim. I'm a triathlete. I have a pellet because it's easy. I have to get it every 3 months and I can swim and it won't come off. And so that was my choice. But more than half of our patients prefer the patch and the cream. I mean, so it doesn't matter.
Whatever is best for you.
Whatever for you and your life.
Everyone is an individual and has individual needs, you had said.
There's different lifestyle needs and some different financial concerns too. I mean, some of these are cheaper than others. And there's a lot of different, we've got to go down the list and really talk to this person in front of me, like, what's the best for you? And hey, you're not married to it. So maybe you try this first and it doesn't work. And then you can come back and we can change it. But, it's got to be an ongoing conversation because you're going to be on this stuff for the rest of your life, I hope. So in my opinion, I want it to be easy.
Yeah.
That was my choice.
Yes. So whatever is the perfect, there's different things for you, and just go in. And again, that goes back to your intuition. Like, what is going to be the best for you? You are the expert
right.
of your body, right? You know how everything feels.
Yeah, you're right. And believe it, because we're taught not to trust our body. I mean, we grew up, women, I'll just say, yeah, I did. I think any of your listeners might resonate with some of this, that unless you're, 20 years old, maybe that is starting to change now. My 20-year-olds are not suffering as much with this kind of prevalent idea that women are crazy. But I grew up thinking that most women's health problems were in our head. And I didn't trust my own body. If the doctor said I was fine, I'm like, oh, I must just be crazy. We've got to move out of that and start listening and trust. And you teach this, right? This is where our coaching comes in, to trust yourself, like have intuition about your own body if you know that it feels different. And one thing I will say, my personal opinion is it's a bit of a red flag if a provider only offers one type of menopausal hormone therapy, or it's just like, pellets are the best, you have to have them, or pellets are terrible, never get them, or go to I have a compounding pharmacy that I own next door, you should go there. Or
yes, right. Little red flags where you're like, huh.
So to just keep your ears perked up.
You're not treating me like an individual.
That's right. So menopausal hormone therapy specialists, I think, should be well-versed in everything that's out there. And then lay it out there. Here's the options. Like, I'm not going to tell you not to get a male testosterone product and divide it by 10. If you want to go for it, I'm just going to tell you it's difficult and probably not very accurate, but you get to choose. So I'll just tell you the options and then you choose. But if someone's telling you, especially this one really bugs me, if they own the pharmacy or something, like, and that does happen. And I get it. It's capitalist country, but preying on women when they're at the most vulnerable time, it really chaps my hide. And listen to yourself if you feel like that's happening to you, because like I mentioned earlier, at a certain point, I would have taken anything. If you told me it had cyanide in it, I still would have taken it if it would have made me feel better.
Yes. And the most amazing thing is we can hopefully not get to that part, and not be in that depth of despair. But
yes, if we went back to this perfect scenario where we started early, you could hypothetically get through this whole thing without ever having those symptoms. And wouldn't that be amazing? Like, you don't have to fall into this hole of suicidal despair before we offer you help, which is what used to be offered.
Yeah. Again, sign me up for that one.
Right. So maybe if you checked your hormones annually starting at 40, I would be able to tell you with some degree of reliability when menopause is going to happen. And we could even start treating it before that, so you wouldn't even have any symptoms. That's next level medicine, isn't it? But why the heck not? Like, men would, going back to your first question, men would have done that for sure. They would.
Yes, right. Men, this whole thing would have been,
right.
This would have been nipped in the bud, right?
So let's wait till your penis is withered and bleeding and you can't have sex at all and you've gained 20 pounds and you're suicidal before we give you anything. Like, do you think
honestly, we as women would want to fix that too, because we'd have to deal with it.
Women would have fixed that because they don't want to hear the whining about it.
That's what I'm saying, Listen, what I'm hearing is we all need to whine a little bit more and complain. Right. What is it? The squeaky wheel gets, I can't even say it. The squeaky wheel gets the oil. So anyway, it's time to, we're going to move on.
We love men. And it is, and I will just say it's wonderful that so much attention has been paid to male health, male sexuality. This is so great. I'm super happy about that. But it's like, what about us? So we're not man bashing, and I'm thrilled that all of that bajillions of money was spent on helping men to feel good as they age.
Yeah. And a lot of women are thankful for that too.
Of course.
Actually,
I'm very grateful for ED medicines, I'll just tell you. But and testosterone therapy for men is that they have more than 10 FDA approved products for men. And it makes no sense because we suffer from loss of that same hormone. Mm-hmm. So yes, great for men. Yay. That was good and wonderful. We're not man bashing, but we just need to catch up. Like we need to have the same amount of attention paid to our health. Because if a guy gets all fixed up and is ready to go and his partner has no sex drive, is miserable, not sleeping, and has vaginal dryness, what happens to that relationship?
Exactly. And that was the hot topic that was the number one thing in my DMs, which was, I don't want to have sex. It's affecting my relationship with my partner.
Yeah.
And I'm too young for this. What do I do? I don't even want to have sex. I don't even want to think about it. I don't want to look at it. I don't want him to touch me. Nothing.
Yeah, super common. So there's a fancy name for that. We call it hypoactive sexual desire disorder, HSDD. So it's got a real name. You're not crazy. It's actually got a diagnosis for that. And, sex drive for women is really complicated. So it wouldn't be accurate to say, oh, it's always because your testosterone's low. So if you hear that, that's wrong. There's lots of reasons. Sometimes we have kids that are preventing us from sleeping. Sometimes we've lost the connection with our partner. Sometimes we're on an antidepressant because of the reasons we just talked about, and that wipes out your sex drive. Sometimes we gain weight and we don't feel sexy and we don't want to be naked. And there's so many reasons. But one of them is hormonal. So we've got to check into that one and then correct it. And there are some prescriptions that help with sex drive. There's two. One's called Addyi. One's called Vyleesi. Yeah, personally, they don't work very well. But there's stuff out there. We want to be able to offer everything to that patient. But that is not a 5-minute visit. So when I was if that patient came in and said what you just said, when I was in private practice, I was like, oh, shit. Like I'm looking at my watch and backing up towards the door. Like, I don't want to talk.
I got to eat lunch.
I know. Well, the main reason is because I didn't know what to do about it. It's like, I don't want to talk about that. And I don't know what to do about it. And so
give it another 6 months. Come back.
You're like, right. Yeah, that's my favorite. Let's just watch that and see what happens next year. What do you think is going to happen? It's going to.
I'll be divorced next year.
That's a doctor talk. When doctors say, "Oh, that's when you hear this, like, "Oh, your thyroid's borderline. Let's just check it next year." That is doctor talk for, I don't know what to do, so please go away. Seriously, I've used that language.
Another red flag to look for.
We know what direction it's going.
Mm-hmm.
Let's just watch these two cars crash. Okay. That's great. And because I know how to pick, I was taught how to pick up the pieces. I know how to fix broken bones and call an ambulance, but I don't know what to do about it over here because I'm not a woman.
I don't know how to stop the cars from crashing, but now we do. So it's
not their fault. I was one. It's just a different way of looking at healthcare.
Mm-hmm. So what do you do? And I don't know how extensive clients or patients get in with you. But when someone comes in and says, because here's the thing, everybody wants to have sex. We are programmed to want to have sex.
Yes.
If I come into your office and say, I don't want to have sex, that's not your new identity. That is a problem.
Yeah, it is. So the questions there's a questionnaire. You don't have to go through the questionnaire, but the basic gist of it is, did it used to be better? Do you wish it was better? And is it causing you a problem? And that patient would say, yes, it was better. I wish it was better. And it's causing a problem, right? So if the patient says, no, it's always been like this. I've never had an orgasm my whole life. That's a different problem, right? Or it's not really causing us problems because he had prostate cancer and we're kind of fine being asexual. That's not a problem, right? So did it used to be better? Do you wish it was better? And is it causing you a problem? If so, let's look into it because this is a huge part of who we are. I mean, I'm obviously very excited about sexual wellness because I think it's such a big part of who we are. And it's such a beautiful way to be able to connect, even if you're single, like with your own self, or no matter what gender or what your sexuality is, just that connection with either yourself or another human. We don't want to lose that and just be like, oh, well, it's gone. Too bad. you're just old, so go play bridge. But that's what they used to say. Like, the answer to that question used to be, oh, you're just old, or it's because of the kids, or in any way to say, don't worry about it. And then there's this cliche, right? That then husband leaves or has an affair with a younger woman. It's a real thing. Mm-hmm. Mm-hmm. We need to address it. And this is saving marriages.
Yeah. And I think even giving yourself permission to say, I miss having sex, or I like having sex, or I wish we were having more sex.
Right.
This is something that you're really adamant about, is having those open conversations with your partner. Well, first of all, yourself.
Yeah.
Second of all, your doctor and your partner.
Right. So people who are not partnered can still have a great sex life. Like, that part of us doesn't go away if we're between relationships or if we've chosen not to be in one. So we were built with this. Whatever your belief system is about who created us or where we came from, we've got this ability to have this amazing pleasure and connection. And so why would we just let that go away? That would be like saying, oh, you can't smile anymore. Too bad. Or laughter, done. No more joy for you.
Yeah, you're old. No more smiling. That's terrible. Yeah.
So we really need to look into it. But I will say the most common reason, and this isn't if you're talking about a patient who has a health, they do love their partner. It's not that another reason is I just don't like him anymore.
Yeah, there's a whole other, that could be our next podcast.
Right.
Reasons why you don't want to have sex with your partner, but we'll stick with the hormonal one.
One of them is I just don't like him. Okay, so we're not talking about that one. If you're in a good, healthy relationship, one of the most common reasons is lack of testosterone. So testosterone has been studied in the studies that we scientists, doctors believe are the ones that are believable, called randomized controlled trials. So you take a group and you give one group a pretend medicine and you give the other group the real medicine, and nobody knows who got what. Well, in those randomized controlled trials, women given testosterone in the appropriate dose for women. So that's 1/10 of what men get, not the crazy high doses that some not good providers give out in the community. You don't want it crazy high. Replacing testosterone in that manner improves sex drive in most women, way more than in the placebo arm. So we know that it works. So if we've got a natural hormone that works, why the heck wouldn't we try that? Instead of an injection that you've got to give yourself 45 minutes before sex, that's Vyleesi, or an antidepressant you have to take every night, that's called Addy. Not my favorite. And if you're on those and they are for you, great. But I'm a root cause person. If the root cause is you've lost your testosterone, and also I'm projecting because that happened to me. Literally 2 weeks after I replaced it, I was like, whoa, that guy's sexy. I just had a sexy dream. It's just having those thoughts again, like, oh, I feel something down there.
Yeah.
100% related to testosterone deficiency in my case, and that's not uncommon. Now, if we checked, and this is why you got to check hormones, if we checked your testosterone and it's a really good level, then that's clearly not the problem, right? So you got to think individually.
You can eliminate things and work from there. Maybe you really don't like your partner. No, I'm going back to.
So we don't treat.
You just need date night,
Yeah, we don't treat low testosterone in patients who don't have low testosterone. Obviously.
Yes, and that's another thing with the taboo around testosterone pellets and pellet. What do they call them? Pellet pushers or something like that.
Much, and they give it to everybody without checking, and they raise it way too high, so you get masculine symptoms. I take it. My skin's never looked better because my testosterone's the same as it was, or similar to when I was in my 20s. Mm-hmm. When I was in my 20s, I wanted to have sex 3 times a day. And, there's benefits to putting hormones back that were taken away. And I when I ever meet sort of a hormone naysayer that's like, oh, you don't need them, or it's a natural, just go through it, or that type of opinion. I just think about a little kid. I have 3 kids. You get this little child and they get pumped full of hormones when they go through puberty, and they transform. They turn from a little child into a full-size adult woman with breasts and hair under their arms, and they start bleeding every month. Transformative, right? So if you take that same hormone away, how could you expect nothing to happen? I mean, it's transformative what happens when you take those hormones away, just like when you put them in a kid going through puberty. So if we think of it that way, There's puberty, and then it's the opposite end where those are taken away again.
Yeah.
It changes everything. Almost every cell in our body has receptors for those hormones. Like I said, from your hair to your feet and everything in between.
Right.
Yeah.
And that's an interesting point that you bring up too of, you had mentioned this before, of just being in tune with yourself, whether you're in a relationship or you're not. Because I was considered too young by my previous OBGYN, and he continually dismissed me. I went years without having sex, and I'm in my 30s at this point. Yeah. And I'm like, and I didn't think it was, I really didn't think about it because I was really busy building a business. And I thought, oh, I'm just really focused right now and all these things. And then the more I would talk to people, they'd be like, how long has it been? I'm like, oh, is that weird? And I finally got tested in your office, and it turns out I had low testosterone.
Yeah.
So you can do something that's a very low dose. And I'm telling you, my entire, not just my sex drive, but my entire world changed. I started, my muscle mass, my energy levels, everything just changed for me.
It's so simple, right? And there's hundreds of years, thousands of years of experience in what happens when you cut a man's testicles off. Like they used to make eunuchs so that they could sing in choirs or act as slaves, or all kinds of horrible things that happened in the past. And maybe they still do some places. So we know what happens when you take testosterone away from a man. Their bodies completely change. And why were we so different? We're considered to be so different. When our testosterone goes away, we have a lot of the same symptoms.
Yeah.
Loss, bone loss, lack of sex drive, lack of energy. And so for me, I hear this all the time from patients, like there's sex drive, like the desire to initiate sex. That also correlates for most of my patients and for me with just wanting to do stuff. So maybe Meg, you say, hey, you want to play pickleball? When my testosterone was low, I probably would have been like, oh, I guess, but I'm kind of tired. I think I'd rather watch TV. You're more likely to be like, sure, that sounds great. So you might not, depending on your situation, you might not notice that your sex drive's low, but you might just be feeling like, I don't know, just don't feel like doing stuff. My friend called me to go to lunch and I'm like, I don't know, I don't feel like getting dressed. It seems too hard. That sounds like depression, like going back to that same misdiagnosis that happens so much. Now, not to say you can't have both, because it's pretty damn depressing to be dismissed all the time. So some patients do have depression. I don't want to suggest that nobody should be on antidepressants, but we want to check. If it's a yellow and it quacks, it's probably a duck. Right.
Yeah. Get checked. Got a duck,
Yeah. Might be a zebra, but probably.
You don't check, you don't know what's in there, right? Clearly, you're walking around and you have no idea how this beautiful vessel that we've been gifted, we have no idea how it works. And that's why I'm so thankful for trailblazers like you. I truly, every time I talk about you, which is often, I just describe you as a trailblazer. So, it's interesting that, the women, the 80s babies, 90s babies who are, in their 30s and approaching 40s, do you think if this, menopausal hormone therapy trends up and becomes less taboo, do you think that we might be able to experience menopause completely differently as a whole?
Yes. I think it's going to be in the smoking and tanning bed and the world is flat category. When my 20-year-old girls are 40, they're going to know everything and they won't have any menopausal symptoms because they'll be completely on it and they'll know everything. So it's coming, but it takes about 20 years. And so we're at the beginning of that cycle, but you've noticed there's a massive amount of media attention being paid to menopause just in the past 2-3 years. People like Oprah Winfrey and Gwyneth Paltrow and like big voices are starting to talk about their own experiences and just normalizing it. So that's going to be amazing. And so, yes, I totally believe that the upcoming generation is going to look at menopause like what I went through, the same way that we're like, I can't believe they used to smoke and drink brandy at lunchtime. Like, wow, that's weird.
Right.
But like a madman, when you watch that TV show and they're smoking the whole time and drinking the whole time. That was
inside.
Or smoking on a plane. Can you imagine? They used to smoke on planes.
Oh my God.
But that was so
We've
normal.
learned, people. We've learned. So let's,
Right.
you
So
know.
I have hope for the human race. Absolutely. The young ones coming up. And you're right on the edge, like women who are in their mid 30s to mid 40s, or if they keep their ears open and they're able to advocate for themselves, they're going to have a much better experience. And then they'll be able to live into their 80s and 90s without Alzheimer's and heart disease and osteoporosis and all the stuff my mom has, who's 91 and has every single one of those things that could have been avoided if she had known what we know now, what your listeners know now. So yeah, it's changing. So we're on the tip of the change, but yeah, and we'll look back on this in 20 years and be like, WTF.
Yeah. Like, why didn't we do that? So
Right.
really, you know, the women not even experiencing menopause, but women who are listening to this, or men who are married to women, right? Because
the man problem too affects the whole
the
family.
man problem too, right? Trust.
It affects the whole family when you feel like shit and you're yelling at your kids and don't want to have sex. It absolutely affects the whole family.
This is not just a women's problem.
That's right.
And you know, it's the women in their 30s and 40s who don't know about perimenopause, who think, I don't know what's going on. Be on the lookout, because this will be less taboo the more we pay attention to it. So if you're not ready to go in and see a physician, just pay attention to your body, right? Then maybe you're ready to go in and see a trusted practitioner who is educated in this and just get some baseline, right?
Yes.
And then we can't tell you what to do from there because everybody's different.
That's right.
But at least you'll have options, because honestly, it's just nice to have options.
There's lots of options. The one thing I can tell you 100% certainty is if you're a female listening to this, you will go through menopause. Mm-hmm. You will. And so knowing that, wouldn't it be great to become educated about it before that? It just seems so simple.
Yeah.
If I told you, Meg, you will get breast cancer in 5 years, I bet you would spend the next 5 years learning every single thing you could about how to treat it, what to do, of course you would, because it's serious. But this is serious. Like, come on. I mean, really, we've got to just reframe it.
And it's 100% known, right?
100%. I'm telling you 100% you're going to have menopause.
Yeah. You and my friend, years ago told me that. What? Burst in my bubble. I've accepted it now. But yes, you are going to go through
me. I don't think I ever articulated that, but on some subconscious level, I truly thought that wouldn't happen to me. And how freaking crazy is that? I'm a gynecologist. So when it did happen to me, I'm like, this can't be happening.
What? Me too? What?
Right.
Yeah. So get ahead of it. There's tons of resources, and I'll make sure I tag all of your amazing resources.
Yeah.
You and I love to have a lot of fun together. We talk about this stuff all the time. We talk about this in really special places all over the world, like Costa Rica. We're going there in November together. So what can people expect for hold on, let me start this over. What can people expect from the next Empowering Midlife Wellness retreats? This theme that we're going with, this happiness and menopause theme. What are we doing in November? Yeah,
so the women's retreats are seriously the most fun thing that you've ever done in your whole life. Like, Meg will probably agree. Like, I've never had such a good time. I look forward to this like there's nothing else. So this year, we'll put a link to it below. We're going to this amazing place. Meg's been there. Just literally 20 minutes south of the Liberia airport in Costa Rica. So really easy to get to. We rented out the whole place because it's this super cute, very intimate place that only will house 40 people. So there'll be 40 women. The recommended age group is sort of 40 to 60, but we're not taking birth certificates. If you're younger or older, just fine. If you feel like this is a subject that resonates with you. And we're not sitting in a classroom with PowerPoints or anything. I mean, we get up in the morning, we do yoga, there's meditation, there'll be some casual talks. I'm going to be speaking about menopause in the kind of girlfriendy way like this, so you can ask questions, putting together a whole life wellness plan for you. Meg's going to be talking about some amazing things as well. And then we have our dear friend Kelly Workman doing some movement work. And then our resident shaman Shanti doing some amazing stuff in the evenings, dancing, having fun, catamaran cruise, great food, all the things. I mean, it's fun. 4 nights of bliss with women who are in the same stage of life. Again, you might be 38 and make best friends with a 70-year-old because you're going to connect on these same issues that we all share because we're all women. And one thing we all know is we're all going through menopause. We're either going to or we already have. So we have that in common. So it's just a lot of fun. So please come, and it's just the best time.
It's in November. It's the 11th, 12th.
It's the 12th through the 16th.
Yes.
I hope so. Yeah.
Yes. I'm like, I think I'm getting there a day early. Maybe that's why I said it. But the 12th through the 16th and the 15th is my birthday. So if you'd like to come to my birthday party in Costa Rica,
that's right.
Come and join us on the retreat. I'll tag all of those resources so you can come and join us. But that will be so much fun. We have girl talk like this for 4 days straight. I've never laughed so hard in my entire life. And don't worry, will not be sharing why on this podcast, but we just have the best time.
Yes, we developed a new term, which is fart friends. It might be something to do with the laughing. However, these are the kind of things that happen on retreats.
Things happen. These are women's issues.
We don't know what's going to happen because we don't know who's going to be there. The people who go create the experience, but it's always amazing and wonderful. So come and have fun, and you're worth it.
Yes, you are. This is definitely, it's an investment, just not even just for your body, but for your soul, for your mind, for your peace, for your happiness. And they're magical. So we will see you there. And once again, Dr. Susan, thank you so much for coming on the show. You're one of my dear friends. I'm just always so grateful every time you come on and educate my listeners, because sometimes we really don't know. We're walking around with this thing and we don't know what's inside. So thank you for debunking all of these questions. I have a feeling we're going to be doing a part 2 because I had probably had 15 more questions that we didn't even get to.
There's a lot, but now you know a little bit. Maybe you know enough now to pique your interest to go out and buy a book like Estrogen Matters. Or my friend Mary Claire Haber published a really great book called The New Menopause. That's another really good one. Or stuff that's on my YouTube channel. There's a lot of stuff out there. I would just make sure you're getting it from a reputable doctor who is probably a member of the Menopause Society. That's a great website also, menopause.org. It shows a list of doctors who've done training in menopause. So somebody that would be more likely to not dismiss you. Mm-hmm. So get your information from a reputable source. There's all this Instagram bullshit nonsense out there. I'm on Instagram. Mine's not. But
yes, you have a great Instagram. So I will definitely tag that, because do not go out and Google. You can Google anything and find whatever answer you want. So trusted resources, people who are treating you like individuals, people who are really treating you like a person, really, right? Because that truly is what you deserve. So
believe in yourself. I'll just leave you with believe in yourself. If you feel something's different, it's different. And don't let someone tell you that it isn't. Trust yourself. You know yourself better than anyone else.
Yeah.
I'm so glad to be back again. And anytime, this is my favorite topic to talk about.
Yes. It exudes, out of your...
Which we will do in November on this retreat, by the way. We will talk about it all day if you want.
Yes. So come join us. So I will
be on the beach talking about it on our private beach.
Private beach.
Under a coconut tree or around a fire or something like that.
The fire pits, the pool is ginormous.
No PowerPoints allowed. No, we're not sitting at conference tables. We're lounging.
There's hammocks. I spent a lot of time in the hammocks the last time that we were there. That was magical. So well, we will see you then together, and we'll leave you with one last message, which thankfully, thanks to you and your research, we can do this as we go into perimenopause and menopause. And that is this: expect good things always, and they will happen.